I'll scroll the images first. That's the axial coronal. So she's a 62-year-old female. She had past history of rectal cancer and had solitary met in the left lobe, and that's why you see changes from segmental resection here. But after many years, she presented with abdominal pain and CT done. Any thoughts? Do I need to scroll more? One sec, I'm trying to get my chat window here. Don't see it.
I will, I'll tell you what the chats say, but
Okay.
can you scroll some more?
So from front to back on the coronal images. Axial. This is MR, maybe better contrast resolution on MR. So focus is on the bile duct.
Yeah, it looks like there's a lot of thickening of the bile duct. Steve is asking maybe if it's a cholangio.
It's a form of a cholangio.
Soft tissue growing into the bile duct, Anu says.
So this was intrapapillary mucinous neoplasm of the bile duct, which is a form of a cholangiocarcinoma, a rare type of cholangiocarcinoma, because cholangiocarcinoma, if you remember, like has three forms. I'll move to my presentation, an intrahepatic mass forming that we classically see, that is T2 hypointense or delayed enhancement with capsular retraction. The second common presentation of cholangio is periductal infiltrating and typically involves the hilum, so we call it as a Klatskin tumor. And the third, the rare type is the intraductal papillary neoplasm. These are often low-grade malignancies. Some can be high-grade, but typically these are low-grade. And this is analogous to your intraductal papillary mucinous neoplasm of the pancreas. So they both present with ductal dilatation. There's soft tissue growing into these dilated ducts, and the ducts are dilated because typically these tumors produce a large amount of mucin, and this can result in obstruction of the ducts. So for such an imaging appearance where you have dilated ducts, some soft tissue growing within the ducts, your differentials are recurrent pyogenic cholangitis, but that's the demographics are different, young Asian immigrant population, and they have more of ductal strictures and pigmented intraductal calculi. And sometimes these papillary neoplasms can form cystic lesions in the liver. So then the commonest differential for those tumors become hepatic mucinous neoplasms. So on imaging, this is an example of an IPNB from literature where it becomes like a big cyst with solid component within it. And this needs to be differentiated from a hepatic cystic mucinous neoplasm. On imaging, differentiation may not be possible. It's more of theoretical or pathologic difference between the two. IPNB lacks ovarian stroma, and hepatic cystic mucinous neoplasms typically have ovarian stroma in their wall. So that's the pathological difference between the two lesions. And IPNB typically, like they are rising from the bile duct epithelium. So they are within the bile ducts, whereas cystic hepatic mucinous neoplasms do not communicate with the bile duct. So these were some of the teaching points related to that tumor. And to think of differentials of intraluminal tumors of the bile duct, I mean, your common lesions are calculi and adenocarcinoma, but some of the uncommon ones is IPNB, as in this case. Then there's intraductal tubulopapillary neoplasm. Again, depends on what type of epithelium it's arising from, or an inflammatory pseudotumor. And others are just a benign adenoma, and metastasis and lymphoma are just like universal things that can involve the bile duct. Okay, so.
Gitanjali, how did they diagnose this? I assume they didn't go back for re-resection because they already resected part of the liver, right? So they got it on like a brushing or?
Yes, yeah, a biopsy. Yeah, they did a biopsy. Yeah.
Okay. Yeah, cool. Those are rare. Or,
Yeah, these are rare. Like, I've been looking for it.
Whoever A is got it before you told us the diagnosis. So congratulations.
Oh, perfect. Yeah, nice.
IPNB with malignant transformation.